My name is Laila Lorenz and I'm from Germany, actually from the University Hospital in Tübingen, and I'm one of the neonatologists there. And why am I here in Copenhagen? Well, currently I'm actually looking after my two twins. They are 7-month-old, but still I'm here. So maybe because your houses are more colorful than ours, maybe because your boats are nicer or bigger than ours, but I think that's not the main reason. The reason is that I got a phone call from my head of department, Christian Poetz, who said, well, Laila, do you remember that we wrote the review about prevention of BPD in extremely low gestation age neonates? I was invited to give a talk at Copenhagen, but I can't go. Do you mind going and giving a talk? And well, that's why I'm here now. To give you a small outline, what I'm going to talk about is I will start with the definition, some words about pathogenesis, and then mainly focus on prevention strategies such as avoiding mechanical ventilation, ventilation strategies, corticosteroids, caffeine, vitamin A, and the eradication of ureaplasma. But before going into further detail, I would like to ask you, what do you do in your neonatal unit to prevent BPD? I've listed all the options here, and I would like to ask you to answer the questions on Slido, and you can answer multiple answers. So it's not one single one, but you can choose like 1 to all of them or just 3 of them. Okay, still moving a little bit, but we see the trend. Avoiding mechanical ventilation, quite a lot of us do. Caffeine citrate is quite popular. Using specific ventilation strategies, number 3, and giving steroids, number 4. Hardly, just a few of us give vitamin A or eradicate ureaplasma. So I will start with some words about definition. It's not new for you, but still I think we need to tell it. BPD is a chronic lung disease in which a preterm infant at 36 weeks gestation receives an FiO2 of above 0.3 to maintain an SpO2 above 90%, or fails to maintain an SpO2 above 90% for 30 minutes during a stepwise reduction in FiO2 to 0.21. BPD was first described in 1976 by William Northway. He was a pediatric radiologist, and he found an association between severe lung injury and oxygen exposure as well as mechanical ventilation. At these days, people ventilated preterm infants with 80 to 100% of oxygen and with really high pressures. And their gestational age of the infants that survived with BPD was around 34 weeks gestation. So it's quite different from nowadays, where our extremely preterm infants have BPD. So the overall BPD rate hasn't changed, but the difference is that the older infants had BPD with 34 weeks, and now it's mainly 28 and less. We talk about 2 different BPD phenotypes. The old BPD that was described by William Northway, which has cystic areas, and it's also called the bubbly lung. And it is mainly caused, as already mentioned, by oxygen exposure and mechanical ventilation. The new BPD is mainly caused by an arrest in lung development. And the X-ray, as you can see here as well, it's quite different. It's a ground glass opacity. We have lucencies, small cystic ones, but they're not so bubbly and big cysts. And to understand what actually happened in these arrest in lung development, I think this illustration is very nice. So you have here an illustration of the intrauterine lung development. And you can see there are 5 stages here. And here is the gestational age listed. And if you look at the 24 weekers here, The 24-weekers, they've just developed their respiratory bronchioles and are just starting to develop their alveolar ducts. And it's not hard to imagine that these lungs, when they are born, are quite vulnerable to stress and any other factors such as inflammation. Prediction. How can we predict BPD from time course of FiO2? Is this possible? There's a big cohort study looking at preterm infants less than 28 weeks, and they grouped all these infants in 3 groups. The EPPD group, this is the upper one here, is the early and persistent pulmonary dysfunction group. They start with a reasonably high FiO2, which increases over time, and the majority of them need mechanical ventilation. There's the PD group, pulmonary deterioration group. They start with an FiO2 of around 30%. They decrease within the first week of life. Some of them don't need mechanical ventilation anymore, and then they start to increase again. And there's the consistent low FiO2 group that don't need a lot of oxygen. And as you can see here, the chronic lung disease percentages of these 3 groups are quite different. What about the clinical relevance? Up to 1/2 of preterm infants within gestational age less than 28 weeks develop BPD, which is a major cause of early death. Those who survive have increased risk of neurodevelopmental impairment and respiratory problems later in life. So how can we prevent BPD? This illustration here shows nicely how mechanical ventilation might cause lung injury. It's an animal study in rats that ventilated rat lungs, and here on the left side, that's a normal rat lung. This lung here was ventilated for 2 minutes with reasonably high pressures, and you can see here on the left apex a little bit of atelectasis. And this lung here was ventilated for 20 minutes with really high pressures, and you can see this massive pulmonary edema of this rat lung. So it's not hard to imagine that mechanical ventilation might cause lung injury. And now, before I go into evidence-based medicine, I would like to ask you, what do you do in your NICU to avoid mechanical ventilation? Again, multiple options. You can choose multiple options, not one single one. You can choose CPAP, LISA, non-invasive surfactant administration, vasonasogastric tube or thin catheter, insure, so intubate, give surfactant and extubate, non-synchronized NIPPV, non-invasive positive, intermittent positive pressure ventilation, or synchronized NIPPV. In the meantime, you've probably chosen your answers already. Let's see what we get. So 96% CPAP. Quite a lot of people use LISA, so more than 50%. More than 50% use insure. Synchronized versus non-synchronized is more or less 50-50, like half-half. Okay, let's see what the evidence tells us. Here, it's a comparison, it's a meta-analysis comparing CPAP versus intubation. And as Brad already explained how it works, I still quickly give you an overview what the forest plots show us. So this diamond here goes towards the left. And if it goes towards the left, it favors the intervention. In this case, it favors CPAP. If the diamond goes towards the right, it favors the control. In this case, it favors intubation. I would need to show you a couple of forest plots, and you will see a lot of numbers here. Don't look at the numbers. I will try to give you the take-home message, but I still need to show you the evidence. So in this case, CPAP versus intubation, the primary outcome here on the top, or the outcome, is death or BPD as a combined outcome. And as you can see here, the diamond goes towards the left, and we have a 9% risk reduction for death or BPD using CPAP compared with intubation. Looking at death itself, there's no difference. Looking at BPD itself, there's no difference. This meta-analysis included quite different variations in administering surfactant, and that's why this broad meta-analysis actually tried to divide this into different ways. So they compared insure versus LISA versus CPAP, and with control of mechanical ventilation. And as you can see here, insure, it's a trend towards less BPD, so outcome was BPD alone. Lisa, there was a 47% lower likelihood in BPD, and there was no difference seen using CPAP. What about NIPPV? Some of you said around 30% that they use either synchronized or non-synchronized NIPPV. This Cochrane review looks at NIPPV versus CPAP early after birth, so in the delivery room, and it showed no difference regarding the outcome BPD. They looked at synchronized and non-synchronized, and they could show that there's a trend towards less BPD using synchronized, but in total, no difference. However, all of us know that some infants need mechanical ventilation. And what is the best way to keep them off the ventilator once we extubate them? And again, NIPPV would be or can be one solution. This Cochrane review compares NIPPV versus CPAP after extubation. Again, they did a subgroup analysis looking at synchronized and non-synchronized NIPPV, and as you can see here, it shows that it leads to a 36% risk reduction for BPD using synchronized NIPPV, but not non-synchronized NIPPV. So which ventilation strategies do you use most in very preterm infants now that we go from non-invasive to invasive mechanical ventilation? If you could choose one of them and you only think about the very tiny ones, which one would you use? Pressure-limited ventilation in your neonatal NICU, in your neonatal unit, volume-targeted ventilation, or elective high-frequency ventilation? And I'm not talking about rescue high-frequency ventilation. In this case, I would ask you to just choose one question if possible. Okay, 66% would use volume-targeted ventilation. Some use high frequency, and the minority uses pressure-limited ventilation. Let's see what the evidence tells us. What is the best ventilation strategy to avoid BPD? All of you have heard about pressure versus volume trauma. However, I thought it's nice to give you a little bit of evidence or animal studies that actually tested this. This is an animal study, again, ventilating rat lungs, and they ventilated them with high pressures and high volume compared with low pressures and high volume compared with high pressures and low volume. And as you can see here in the bars, it's easy to see that low pressures and high volume causes the most pulmonary edema, which is a surrogate parameter for lung injury, and high pressures and low volume was best. Clinical studies actually confirmed these observations. Here, again, a Cochrane review looking at volume-targeted versus pressure-limited ventilation. And as you can see here, the diamond goes towards the left, favoring the intervention. So volume-targeted ventilation led to a 32% risk reduction for BPD. What about elective high-frequency ventilation? Again, a Cochrane review. The diamond goes towards the left. It led to a 14% risk reduction for BPD. However, it needs to be mentioned that all these studies are reasonably old, and the comparison group is pressure-limited ventilation and not volume-targeted ventilation. Quite a lot of forest plots. You're falling asleep. What can we do? Maybe I change the topic from ventilation strategies to corticosteroids. It might help, it might not help, let's see. Inflammation plays a key role in the development of BPD. Are corticosteroids the magic bullet? But again, I need to show you some forest plots. Early dexamethasone, less than 8 days versus placebo. And you can see here quite a lot of studies contributed to this Cochrane review published in 2017 by Lex Doyle. And it shows that early dexamethasone led to a 29% risk reduction for BPD. These studies are mainly published in the 90s, and a lot of people started to use dexamethasone thinking, well, we have the big solution for BPD. But then in 2000, Shinwell published an association between early postnatal dexamethasone and the incidence of cerebral palsy. And then the summary of these data on all the studies that are published so far showed actually a 75% risk increase for cerebral palsy. And that's when all of us stopped using dexamethasone, especially early dexamethasone. And can be nicely shown here in this graph published by Yoder, who actually showed the decrease of dexamethasone use over time. You have here on the x-axis 3 different epochs shown. Epoch 1 from 97 to 99 until epoch 3, which goes until 2006. And it's divided by all these 5 gestational age groups. And as you can see here, the black bars is the BPD rate, and the gray bars is the dexamethasone use. And if you only look at the 24 weekers here, you can see that the dexamethasone use goes down from 80% in 1979 to 40% in 2006, leading to an increase in BPD rate from 60% to 80%. And the same trend that was observed in the 24 weekers is similarly for all other gestation age groups. And then the DART study was published, and all of us know the DART study. It was published by Lex Doyle in 2006, looking at a low-dose late dexamethasone course that I've listed here once again. And it showed that it facilitated extubation and shortened the duration of ventilation. And he gave the dexamethasone, or this study gave the dexamethasone to preterm infants that were only ventilated and that were hard to extubate, and the mean gestation age was around 22 days. They showed no difference in death and disability with 2 years of age, which was very promising. And this study actually reopened the debate regarding low-dose dexamethasone. So this is the summary Cochrane review from Lex Doyle again, late dexamethasone versus placebo. And as you can see, the diamond goes towards the left, and it shows a 23% risk reduction for BPD. There was no difference in cerebral palsy, and that's why probably quite a big percentage of us still use late dexamethasone. However, adverse effects need to be listed here because late dexamethasone is not without any side effects. It increases the risk for hyperglycemia, hypertension, hypertrophic cardiomyopathy, and severe ROP. There's a trend towards an increased risk for infection, gastrointestinal bleeding, but there's no increased risk for NEC, gastrointestinal perforation, or blindness. What about early hydrocortisone? Not only dexamethasone can have an effect on BPD, but also hydrocortisone. So early hydrocortisone, less than 8 days versus placebo, here in the Cochrane review, showed no difference regarding BPD and no difference regarding cerebral palsy. However, also included in this Cochrane review is the study published by Bord in 2006. That's the French study that I would like to mention here, the Premilog study. They looked at the primary outcome, survival without bronchopulmonary dysplasia, and actually could show that there's a 48% higher likelihood in survival without BPD, even though the 24 to 25 weekers had a higher sepsis rate. What about inhaled corticosteroids? So inhaled corticosteroids might have less side effects because it's not working systemically. Cochrane review again, I need to show it to you, I'm sorry. Early inhaled corticosteroids leading to a 23% risk reduction for BPD. But if you look here, the study published by Dirk Butler in 2015, the Neurosis study, contributed most to these results. And if you look at his follow-up data for 2 years, it shows a 40% risk increase for death with 2 years, which is quite disappointing. What about surfactant and budesonide versus placebo? A group from Taiwan published quite promising results using the administration of budesonide using surfactant as a vehicle. And they showed actually that the BPD rate significantly could be reduced using budesonide and surfactant, as well as death and BPD. They included infants less than 28 weeks. Their inclusion criteria were around 50% of oxygen, and they mainly did it in their area, so it's not a big multi-center trial. These data need to be replicated in a big setting to be able to tell us if we want to change clinical practice. And it's actually on the way. Brett just told us a lot about high flow, but he's not only working with high flow, he's currently conducting the PLUS trial, and who had the primary outcome survival rate free of BPD. The sample size is 1,030 preterm infants less than 28 weeks, and we hope that this results might help us to decide, do we want to give surfactant with budesonide to extremely preterm infants. Again, a small little break, and now I hope it's a break for me. A multiple choice question for you, and see if you have paid attention. This time only one answer is correct, and I would ask you to choose using late dexamethasone. There's no increased risk for gastrointestinal perforation, hypoglycemia, ROP, hypertension. So only one answer is correct, and the one that is no increased risk should be clicked. Well, 57% have chosen the correct answer, and that's great. So not all of you have fallen asleep. So I'm going to talk about two more drugs, just to give you a small little overview what else might help to prevent BPD. Caffeine citrate. All of us know caffeine citrate. Probably the majority of us need a cup of coffee to start their day, and as we've heard this morning, it's quite important for us. So caffeine citrate, all of us use probably in their NICU, and Barbara Schmidt became quite famous with the CAP trial, caffeine therapy for apnea of prematurity. And she looked at the effect of caffeine versus placebo in infants less than 1,250 grams. She also looked at BPD and showed that there's a 37% risk reduction for BPD. Moreover, an Australian group could actually show that a cohort of these CAP infants had an improved lung function at 11 years of age. And a subgroup analysis published showed that early administration of caffeine, so less than 3 days of life, leads to a 52% risk reduction of BPD compared with giving caffeine late, which led only to a 23% risk reduction for BPD. What about vitamin A? We know that vitamin A deficiency in laboratory animals produced histopathological changes in the respiratory tract. Similar changes are observed in ventilated preterm infants with chronic neonatal lung injury, leading to the suggestion that vitamin A deficiency might contribute to such injury and might be resolved by restoration of adequate vitamin A status. Again, a Cochrane review looking at vitamin A versus placebo, and they looked at intramuscular as well as oral administration. And as you can see here, giving vitamin A intramuscularly led to a 15% risk reduction for BPD, but there was no difference seen for oral vitamin A. What about the eradication of ureaplasma? There has been shown that there's an association between the colonization of ureaplasma and BPD, and that's why the thought came up that we might eradicate ureaplasma to prevent BPD. Azithromycin might be one option, and it has been tested versus placebo in ventilated preterm infants. And as you can see here in this meta-analysis, it led to a 17% risk reduction for BPD. Another option would be clarithromycin. It's a more potent macrolide, and it has a better toxicity. But this group here tested clarithromycin versus placebo in only ureaplasma positive preterm infants. They had 33% of their preterm infants were ureaplasma positive, and the BPD rate in ureaplasma positive infants was 36.4% compared to 15% in the ureaplasma negative infants. And then they treated the ureaplasma positive preterm infants with clarithromycin and showed a quite significant decrease in BPD. So in conclusion, I would like to list a couple of things that I can recommend, but still it's how to interpret the evidence. CPAP instead of mechanical ventilation as primary support is something I would recommend, and as we saw in the very first beginning, the majority of us do already. Surfactant via minimal invasive administration, such as laser or maybe insure. Volume instead of pressure targeted ventilation. Synchronize NIPPV instead of CPAP after extubation. Caffeine on postnatal day 1 to 3 instead of later. Vitamin A intramuscularly. Dexamethasone in infants requiring mechanical ventilation at the end of week 2 to 3. And azithromycin on ureaplasma positive ventilated infants. Thank you very much for your attention.